Your face is downstream of your foot. That sentence will probably make you want to close this. I understand that. And I'm going to give you exactly 90 seconds to test whether it's worth your skepticism. Because the test is physical, not theoretical, and you can do it right now in your chair. Press 2 fingers into the arch of your bare foot. Not the ball, not the heel, the arch. Press upward as if you're trying to push the arch away from the floor. Hold that pressure for 15 seconds. Now release. Notice anything in your jaw, your temples? Some people notice nothing. Some people notice a very slight release around the eyes. I want you to hold that observation, whatever you noticed, without interpreting it yet. We'll come back to it. Here's what I've tracked for several years now, across dozens of patients who came to me for general postural and musculoskeletal work. When I add foot mobilization, specifically work targeting the intrinsic muscles of the plantar arch, patients would sometimes mention, unprompted, that something had changed in their face. Not dramatic, not universal, subtle. The kind of thing they'd notice in a photograph comparison 2 weeks later. Lighter around the eyes, a small shift in how the temples were sitting, the jawline marginally more defined. I didn't set out to study facial aging. That's not my lane. So the first few times it happened, I filed it away. The 10th time, I started paying closer attention. The observation wasn't what those patients were telling me. It was the pattern behind what they were telling me. 3 data points arrived within roughly the same 6-month window, and when they came together, the mechanism became almost obvious. I'll take you through each one because the assembly is the argument. If I just tell you the conclusion, you'll reasonably dismiss it as clever speculation. But if you watch these 3 things land in sequence, I think you'll feel the same click I did. The first point came from the anatomical literature. Thomas Myers, who spent decades mapping what he called fascial lines, continuous pathways of connective tissue running through the body, described something he named the superficial back line. This isn't a metaphor. It's an anatomical structure you can trace with your hand if you know where to look. It begins at the plantar fascia, the sheet of tissue under your foot. It runs through the Achilles tendon, up through the gastrocnemius, through the hamstrings, crosses the pelvis through the sacrotuberous ligament, runs alongside the spine through the thoracolumbar fascia and the erector spinae group, passes through the posterior neck musculature, and ends, this is the piece most people never reach, at the brow ridge, the forehead. 7 distinct anatomical segments, 1 continuous structure. Myers' work was published in Anatomy Trains, and while it was initially met with some skepticism from researchers focused on segmental anatomy, subsequent dissection studies confirmed the functional continuity of these pathways. The debate in the literature isn't whether these lines exist. That's been settled by direct anatomical dissection. The debate is about how much independent load-bearing each segment contributes. That's a different question entirely. Let me back up for a second. Before I get to the skull end of this line, I need to establish something about the foot end, because the foot is where the tension originates, and the nature of that tension isn't what most people assume. The foot has 2 categories of muscle. Extrinsic muscles, the long muscles of the calf and shin, move the foot from a distance. The intrinsic muscles live inside the foot itself, the lumbricals, the flexor digitorum brevis, the abductor hallucis. Their job is to hold the medial longitudinal arch upright from the inside, like a suspension mechanism. When they do their job, the arch holds its shape under load, the plantar fascia stays appropriately tensioned, and the force transmission up through the leg is organized and efficient. When they stop doing their job, and in modern footwear, with prolonged sitting, they often do stop, the arch collapses medially. The plantar fascia stretches and thickens at its insertion, and the tension in that structure shifts from dynamic and responsive to chronic and passive. The foot is no longer a spring. It becomes a slack structure compensating under load. And that compensation travels. It travels up. The second point came from the research context around what's known as the Fascia Research Congress, a gathering that's produced some of the most rigorous cadaveric and imaging work on connective tissue behavior. The work I'm referencing specifically concerns the suboccipital muscles. These are 4 small muscles at the base of the skull, named rectus capitis posterior major, rectus capitis posterior minor, obliquus capitis superior, and obliquus capitis inferior. They sit at the junction between the base of the skull and the first two cervical vertebrae. And their job is fine-tune positional control of the head on the neck. They also have an attachment that most anatomy courses don't highlight. They connect to the dura mater, the outer covering of the spinal cord, through a small but significant fibrous bridge. And they connect through the posterior cervical fascia to the Galeal Aponeurotica, a broad fibrous sheet of connective tissue that covers the top of the skull like a cap pulled down over a melon. The Galeal is what I want you to understand, because the Galeal is the structure nobody talks about in conversations about facial aging. It sits between the scalp and the skull. It connects forward to the frontalis muscle, the muscle of the forehead. It connects laterally to the temporal fascia over the temples. And in cadaveric studies, examining the relationship between posterior cervical tension and galeal mobility, researchers found that when the suboccipitals are shortened and the posterior cervical fascia is under increased tension, galeal mobility decreases measurably. The sheet over the skull gets pulled backward and downward. The frontalis follows. The temporal fascia follows. The tissues anchored to these structures follow. This is where I have to be careful. Let me be precise here. The research doesn't say suboccipital tension causes facial sagging. What it shows is that posterior cervical and suboccipital tension reduces the anterior mobility of the galeal tissue, which normally allows the forehead and periorbital area to sit in a more elevated, uncompressed state. That's a much more specific claim, and it's one the anatomy supports. So, the superficial back line runs from the plantar fascia to the brow ridge. The suboccipitals, which sit partway along that line, connect to the Galeal. And chronic tension in the foot changes the tension signature of the entire posterior chain. That's where the third point comes in. When I began looking specifically at patients who presented with both intrinsic foot muscle inhibition and complaints about facial heaviness being a word many of them used, I found a consistent pattern. These were not people with severe postural problems. They were ordinary adults, mostly in their 50s and 60s, who spent a lot of time on hard floors in supportive shoes. Nurses, teachers, people who walk on concrete for a living. Their feet looked fine from the outside. The arch wasn't dramatically flat. But when I tested the intrinsic function, specifically the ability to dome the arch under load without curling the toes, there was significant inhibition. The muscles existed. They weren't atrophied to the point of clinical concern. They just weren't firing in the right sequence. And the pattern at the other end of the chain, the suboccipitals in these patients were consistently shortened and tender. The Galeal was consistently restricted in its anterior glide. The frontalis showed elevated resting tone. Now I want to be direct about what this means in terms of the evidence, because this is where the honest version of the story gets complicated. The mainstream position in aesthetic medicine on facial descent is this: faces age through a combination of gravitational descent of fat compartments, bony resorption of the facial skeleton, volume loss in the subcutaneous layer, and progressive degradation of dermal collagen and elastin. Botox works on dynamic wrinkles by temporarily paralyzing the muscles that create them. Fillers restore lost volume. These are real mechanisms. The research behind them is substantial. If someone says Botox doesn't work for its intended purpose, they're wrong. But here's the question that literature doesn't answer. What creates and maintains the chronic downward tension on the periorbital and forehead tissue between gravity's episodes? Gravity is constant, yes, but the degree to which tissue yields to that constant force depends on whether there is counter tension holding it. A tent doesn't collapse because the wind increased. It collapses when the stake at the far end pulls free. The aesthetic literature maps the tent. It doesn't spend much time on the stake. Think of it like a theatrical production. The whole thing is designed around the actor hitting their mark, the precise spot on the stage where lighting, sound, and camera converge. Every adjustment made to the lighting rig, every mic placement, every camera angle is oriented around that mark. If the actor hits the mark correctly, everything works. The production looks polished, luminous even. Now here's where the theater analogy breaks. Because in this situation, there's a rope tied to the actor's belt. A thin rope running backstage, pulled taut by something behind the curtain. The actor is trying to hit their mark, but the rope keeps pulling them 3 feet downstage. You can adjust the lighting all day. You can add more rigs. You can bring in a better sound engineer. The actor is still going to drift. The rope is the problem, and the rope starts in the foot. The analogy breaks down cleanly because a rope is discrete with clear endpoints, and this tension is distributed, gradient, and mediated by multiple segments. There isn't one rope. There's a continuous sheet of tissue under different loads at different points. But the principle that something backstage is maintaining a pull the front of house solutions aren't designed to address holds. Now, what to stop doing? This is the part that matters for your next 48 hours. There are 3 patterns that maintain posterior chain tension specifically through the foot, and most people are doing at least 2 of them without knowing it. The first is passive floor contact while seated. When you sit with your feet flat on the floor and your weight driven forward into the ball of the foot, the plantar fascia is under a stretch it isn't actively managing. The intrinsic muscles, with no load-bearing tasks to perform, downregulate. They stop contracting. They stop contributing to arch position. Over hours and hours of this pattern every day, the arch loses its active support system. Stop pushing your weight into your feet while seated. Let the foot rest lightly. Weight on the heel, toes relaxed and long on the floor. The second is toe gripping. This is the habit, completely unconscious in most people, of curling the toes slightly downward when walking or standing, particularly on hard surfaces or in shoes with no grip. Toe gripping substitutes for intrinsic arch engagement. It looks like it's doing something useful. It's floppy compensation, not real support. When you grip with the toes, you're recruiting flexor digitorum longus, an extrinsic muscle, for a job that belongs to the intrinsics. Stop doing it. The way to notice it, stand barefoot and feel whether your toes are pushing into the floor or just resting on it. They should be resting. The third is over-supported footwear for all waking hours. A motion control shoe does the arch's job for it. That's the point of the shoe. But a muscle that never has to work stops maintaining its capacity to work. This doesn't mean throw out your orthopedic footwear if you have a clinical reason for it. It means spend some portion of your day, even 30 minutes, in minimal footwear on a forgiving surface, allowing the intrinsic muscles to engage without external support. Now, the 45-second reset. This works through intrinsic activation, not stretching. The plantar fascia stretch, the classic morning heel drop, the toe dorsiflexion, is not this. Stretching the plantar fascia addresses the tissue under tension. This addresses the muscle inhibition that's allowing that tension to persist. Sit barefoot in a chair, feet flat on the floor, weight on the heels, toes long. First, find the arch dome. Without curling your toes, without gripping at all, try to shorten the distance between the ball of your foot and your heel by lifting the arch upward. The toes stay flat, the heel stays flat, only the arch moves. It should feel unfamiliar, mildly effortful, like trying to move an ear. That unfamiliar sensation is the intrinsic muscles being asked to contract in a pattern they haven't used regularly. Hold that contraction for 5 seconds. Release completely for 3. Repeat 6 times per foot. That's your 45 seconds. One cycle of 6 contractions, 5 seconds on, 3 seconds off, each foot sequentially. What you're not trying to do, create a visible arch. Don't force the movement. Don't help it with your toes. If the arch barely moves at all the first time, that's diagnostic information. It tells you the inhibition is significant. The movement will come over days. Do this every morning before you stand up from bed, and again before any period of prolonged standing. The morning timing matters because the intrinsic muscles, like most small stabilizing muscles, are most inhibited after a night of no weight bearing. You're essentially reminding them what their job is before you ask them to do it. In the first 3 to 5 days, most people notice nothing beyond mild fatigue in the arch. Between days 7 and 12, some people begin to notice a change in how their neck sits, a very slight sense of length at the back of the head, less compression at the suboccipitals. The facial changes, when they come, are usually reported in the second week. And I want to be honest, not everyone notices them. The posterior chain is one factor in facial descent, not the only factor. Volume loss is real. Collagen degradation is real. What I'm offering you is not a replacement for any of that. It's the structure underneath that makes everything else work better or worse. The 14-day test is this. Take a neutral photograph today. No special lighting, no chin down, no chin up, just straight ahead. Take another one on day 15, same conditions. Look at the temples. Look at the area just below the brow. Look at the jawline. You don't need me to interpret what you see. You'll know. And the next time you're standing in front of a mirror, studying your face, the next time you're looking at the temple, the brow, the way the tissue is sitting, you'll know to look past the mirror. You'll know to look down at the stage, where the actor is trying to hit their mark. Feel whether the rope is taut, and start there. Try it tonight. 14 days, then you'll have your answer.